Hey y'all, it's Shelby and welcome back to Abby and Shelby RN. Today we're going to go over a head-to-toe assessment and how to accurately do one within the hospital setting. A head-to-toe assessment is so important within the hospital setting because it's the one thing that you have as a nurse during the 12-hour period to really understand how your patient's doing. We have lab results and we have vitals, but those are only retrieved every so hours, and with lab results you have to have a physician's order, so you may or may not have that at your disposal. Being able to do a really good assessment is going to help you in the long run as a nurse, really getting a good picture of how your patient's doing. So let's go over some of the components of a head-to-toe assessment, and I'm gonna go through step by step how I do my head-to-toe assessment within the hospital. I think in nursing school, they definitely scare you as soon as they start talking about assessment. They give you 1,001 questions to ask. It's really your first thing that you have to do when you're a nurse and in nursing school, that you're talking to the patient, you're having to really assess, use your clinical judgment, and it can be a little overwhelming. And on top of that, in the hospital, patients are really aggravated, everyone coming into their room at all hours of the day and night, asking the same questions over and over again. So it's really helpful if you have a quick and efficient and precise assessment. So a head-to-toe assessment is really that simple. You go from the head to the toes, and you're just looking for anything that's normal or really any outliers that really aren't supposed to be there and that are just a little indication of something else that could be happening. I would say 50% of your assessment can be done just by walking into the room and talking to your patient. As soon as I walk into the room and I explain who I am, I ask them who they are. Right there you have one tool in your assessment, and that's orientation. Are they oriented to person? Them being able to tell you that, you asking them why they're here today, they're oriented to the situation and the place. So really just talking to your patient as soon as you walk into the room is going to get you so much information. One of the questions that I just start off with is, what brought you in here today? That's going to open up the whole conversation of exactly why they're here, what they're feeling. You're going to get a good assessment of their speaking, you're going to get a good assessment of their orientation, and it's going to open up the conversation for you to understand if there's anything that's been really bothering them physically, emotionally, all that sort of stuff. Just by those few short questions in the beginning, you have a large majority of your assessment already done. You can see by looking at them their hygiene status. A lot of times we just have elderly patients that come into the hospital that just have failure to thrive. They're unable to take care of themselves, and you can really see that just by looking at them. From those questions, you can already see their mental status. You can see if they're a little bit more withdrawn, if they're really out there and maybe in like a manic state. You can see that just by talking to them. You can also listen to their voice. Is it gargly? Are they having issues talking? Are they getting really out of breath while talking? Those are all things that are done within the first couple minutes of you walking into the room and just asking who your patient is. Now, after getting some of those beginner questions out of the way, I just move on straight to the head. And we're going to start there and just work our way down. So I do the head and all the face, the eyes, nose, mouth, and ears. And then I move on to the neck, chest, arms, and legs, and then I'll listen with my stethoscope. I normally do my full assessment of talking with the patient, assessing, touching, feeling before I even get my stethoscope out. It's just a lot easier to sit and listen to your patient before even getting the stethoscope out to listen. So we're going to start at the head, and you're going to look at the scalp. So you can see a lot of things just based on the scalp. Like we said, hygiene is a really big one. Do they have lice? Do they have any lesions? You can feel around, do they have any nodules or knots that aren't supposed to be there that have been hurting them? After that, I normally go to the ears. You can get your pen light, kind of look around, see if there's any blockages, any drainage happening. After that, you can go to the eyes. This is the one time that you really get to use your pen light. You normally don't use it if you're on a regular med-surg floor unless they have a neuro problem. If you're on a neuro floor, you're going to be using it all the time. But definitely for the pupils, we're going to be using our pen light. And you're just going to shine the light kind of in the corners here on both sides. Make sure that their pupil is restricting. You're going to use PERLA, which stands for Pupils Equal, Round, Reactive to Light, and Accommodated. Accommodation is a little bit harder to do within the hospital setting. You're in tiny hospital rooms and everything, but accommodation is just getting someone to look straight ahead at something a little bit far away for a second, and then putting your pen or your finger in front of them, seeing if their eyes adjust to being honed in on something a little bit closer. So after the eyes, I go to the nose and the mouth, and it's the same thing, just mucous membranes are supposed to be pink and moist. You want them to be intact. You don't want to see any lesions or any sores. That could be an indication for different type of disease processes or just oral hygiene and their health from that. So now we're completely done with the head and we can move down to the neck. This one's pretty self-explanatory in the sense of you're just feeling around, seeing if their lymph nodes are swollen, if their trachea is midline, and if their carotid pulses are good. Always feel the carotid pulse unilaterally, never bilaterally. Don't want to cut off any blood circulation or anything. And just making sure everything's in place and in line where it's supposed to be. From the neck, we're going to move on to the arms, and while I'm doing this, I'm just checking the skin throughout the body. The skin is the number one issue, I feel like, especially in hospital setting. We either have open lacerations, we have surgical incisions, we have pressure wounds. There could be a lot of issues with the skin, so just making sure as you're going down the body, you're checking every skin surface on every part of the body. With the arms, I'm just going to be checking the skin, checking range of motion, kind of checking the skin warmth and muscle tone, making sure the skin's warm, dry, no weeping, no tearing, no open wounds or anything like that. And then when we get down to the hands, we're obviously going to look at the capillary refill in the nail beds. Super important that it's, less than 2 seconds. After that, the nails can tell you a lot of other things, like we said, hygiene. You can look for discoloration under the skin, maybe petechiae or splinter hemorrhages. There could also be another symptom called clubbing of the fingernails, which could be indicative of hypoxia. After I'm done looking, I get them to squeeze my hands, see if there's any weakness on that right or left side. I get them to pull, push, make sure they have good power and normal extension. From the arms, we're just going to kind of move into the chest. We're just going to look now. We're going to get our stethoscope later. We're going to look at the chest and make sure when they take a deep breath that it's expanding here in the chest symmetrically, not one side or the other. And we want to make sure that they're not using their intercostal muscles or their belly to breathe. As we're going, we're asking them questions too. Do they ever have issues with being short of breath? When they walk long distances, are they getting short of breath? Are they having any issues swallowing and feel like they're choking at all? Just asking those questions is really going to get the patient understanding what the assessment's for, and you're going to get a good medical history. From the chest, I move on to the belly. I kind of just feel around with my hand, make sure there's no tenderness, they're not guarding anytime I press on anything. Just make sure there's no pain and no masses anywhere. Then from the belly, we're just going to go down the legs and do exactly what we did with the arms. So we're going to be feeling the skin, checking out the skin, especially at those heels, especially with our diabetic patients that have neuropathy. They should be checking their feet every day, but a lot of times they don't, or they can't see their feet. So checking their heels, since they have that numbness, tingling, and they can't feel it, making sure there's no open wounds or pressure ulcers on those bony prominences. I'm asking if they can feel all the way down, they have good sensation, there's no burning or tingling. And then I'm going to look at their nail beds on their feet just the same way that I looked at on their hands. I'm going to make sure they have a less than 2 second capillary refill, no discoloration, and I'm going to feel the pedal pulse. With pulses, I normally feel the most distal one, so on the hands I'm going to feel the radial, on the feet I'm going to feel the pedal. They're the easiest ones to get to, and they're the most distal from the body. And if they're getting good blood flow, then I know everything else above it's getting good blood flow as well. And for the feet, I do the same thing that I did with the hands. I get them to push against my hands, pull back against my hands, make sure they have good power, no weakness on either side, and good extension and flexion. So after that, we did just one good quick once over. We've been asking questions as we went along. We've been getting a really good assessment by looking and feeling. And now we're going to get our stethoscope out and we are going to listen. Now we get our stethoscope out, and I like to start here back at the neck. I like to listen to the trachea, make sure there's no wheezing or any stridor here just in the trachea. You can hear that normally when you're talking to them, so you would have already known, but just to double check, I go there. And then from there, we can listen to the carotid, just make sure that there's no bruits or anything. From there, we're going to go and we're going to listen to all 5 heart sounds. I know a lot of people like to memorize it as All People Enjoy Time magazine. So that's all 5 of the heart sounds. And you can just start and listen to them. Make sure you get a really good listen to the heart. Make sure there's the S1, S2, the lub-dub, lub-dub. We don't want any S3 or S4 sounds. We don't want any adventitious sounds. We don't want any friction rubs or murmurs or anything like that. We want to make sure that it's just those sounds and there's nothing out of the ordinary. After listening to the heart sounds, I do go to the lungs. I listen bilaterally in the front and the back. We want to make sure that there's no stridor, no crackles, no adventitious sounds in the lungs either. We want to ask them if their breathing has been okay, if they felt short of breath. And this is a good opportunity too. When you get them to sit up to listen to their back lungs, you want to look at their back, look at their skin. That's another really important place to look at for pressure wounds. Our older patients that are really skinny, they have those bony prominences in the back on their sacrum and coccyx, and it's a really common place to get pressure ulcers in a place where they wouldn't be able to check themselves. So after I've listened to the lung sounds, I'm going to move on to the stomach. I'm going to listen to all 4 quadrants of the stomach. I'm going to make sure that I listen for at least 5 minutes in each quadrant before I recommend that anything's hypoactive. You want to make sure you're really listening. Bowel sounds can be a little bit faint sometimes, so you want to make sure that they're actually there. This is a good time to ask your patient too. They might think that they're not having any stomach pain, no issues, but really they haven't had a bowel movement in a week. So just remember to be asking those kind of questions as well. As I'm listening to their stomach, I'm also going to ask about bowel movements and urinary function. I'm going to ask if they have any burning sensation when they urinate, if they have any urgency or any issues starting a stream of urine too. After I'm done with my stethoscope, I normally ask the patient if they have anything else that they're worried about or have any questions about. You make sure you just listen to your patient. They know their body better than you do, and just give the body a good once over again, get your vitals and everything, and then that's it. Head to toe assessments can really be super simple if you break it down by each body system, making sure you're asking the right questions and really just being as thorough as you can be. Remember to listen to your patient. They know their bodies better than we do, and if you're really listening, your head to toe assessment is going to be amazing. That's all I have for you today. I hope this was super helpful for any nursing students or anybody that needed a refresher. Make sure to click the like button and subscribe. Turn on the notifications if you want other videos just like this, and I'll catch you next time.